Well, good evening and welcome to the 2020 Pneumococcal Disease Webinar hosted by the Immunisation Coalition. My name's Susie Blackburn, Managing Information and Events at the Coalition. And as you can see, our mission is to advocate for immunisation to protect Australians against infectious disease. It's going to be a busy night tonight because pneumococcal disease is currently very topical with some changes to the NIP and also some really complex issues for discussion this evening. As usual, we have Angela Newbound presenting tonight. I'll introduce her more in a moment to take it away, but would like to say that throughout this session, more than happy for you to please have your questions and answers in the Q&A section. We will come to those both throughout the session, and also at the end we'll have a few minutes where we try and get as many questions as we can answered. So our presenter for tonight, Angela Newbound from the Adelaide Public Health Network. Angela is a highly respected expert in immunisation and also an Immunisation Coalition member. Welcome to you, Angela.
Thank you so much, Susie. Gosh, you've built me up. I'm going to have to be on my game here.
You live it. Well done.
We'll see. Good evening, everyone, and thank you so much for joining us. And hopefully we'll have a really informative hour. And certainly, hopefully, you've got either a glass of wine or a cup of tea in front of you, and we can sit back and enjoy everything around pneumococcal disease, and like Susie said, exceptionally topical right at the moment with the new schedule changes. We're going to kick off first up though with a poll.
Okay, let's get that launched. Are you ready to press your buttons? There you go.
Okay, so what actually causes pneumococcal disease? So select your answers.
Okay, we'll give people a few moments to get to their computers and click the buttons. There's a few changing their answers. We've got about 70% have voted so far.
Ooh, good.
30 or so more seconds. All right, we're nearly there. We've got 80% voted, and it looks like 73% are saying A, Streptococcus, and about 25% with B, Staphylococcus.
Perfect. Okay, thanks, Susie. All right. Okay, so for those of you that have ticked A, Streptococcus pneumoniae is the causative agent of pneumococcal disease. So this is it's quite an old disease. It was first discovered in 1881. So you did really well at selecting that particular answer. We do know that this disease lives quite harmlessly, usually in the nose and throat of, even healthy people and especially young people. They're even saying that, maybe up to half of young people, particularly children, will carry this, particularly during the winter months. However, we know that in vulnerable people, this bacteria does invade the body, and it does get into the bloodstream, or can get into the bloodstream, and causes that invasive pneumococcal disease. So these bacteria have really complex polysaccharides or multiple sugary type protein coatings, and that polysaccharide capsule is what helps this bacteria resist phagocytosis. So it's a really difficult disease for humans to actually control once it does become invasive. So what is pneumococcal disease? Well, there's a whole range of different illnesses that are covered, and some of these are what we would just call pneumococcal disease. Some of these are what's going to be invasive disease. So if we have a little look at this next slide, it probably gives you a little bit more of an idea with this diagram of the progression of the pathway of the disease. So if we're looking at the non-invasive conditions, they're the conditions that occur outside of the major organs or outside of the bloodstream. So if we look at things like otitis media, which is detected in around 28 to 55% of middle ear aspirates from children with otitis media. So it is considered to be the most common bacterial cause for otitis media. So that's pretty significant, and it does sometimes lead to permanent hearing loss in children. So important that young children receive their pneumococcal vaccines for sure. Certainly this bacteria can cause pneumonia. Now, generally a pneumonia itself is not considered to be an invasive disease. However, it can very quickly become an invasive disease. So we need to really watch individuals that do have pneumococcal pneumonia. So we do treat it with antibiotics, but unfortunately there has been growing resistance to antibiotics that just might mean that patients need to be prescribed a combination of antibiotics. But as always, we say that prevention is better than the cure. So definitely educate all of your patients about pneumococcal vaccine recommendations. And hopefully this webinar tonight will give you a bit more confidence to do that with the new changes. So just making sure that you do set reminders in your practice software. Search your databases for any at-risk individuals and call them in if they are eligible or recommended to have funded or unfunded vaccine. So if we're looking at invasive pneumococcal disease, it generally is defined as Streptococcus pneumoniae being isolated in normally sterile sites. So we're looking at blood, or we're looking at pleural fluid, cerebrospinal fluid. I did mention earlier that pneumococcal disease is really fairly common. Realistically, we carry this bug, so for some people it does make us unwell, and certainly likely to be really underrepresented given the problems of diagnosing this particular condition. So it's important that we do monitor these individuals for pneumococcal disease. If they are unwell, if they've got chronic medical conditions, that it's something that we are thinking about as clinicians. We do know that in children, primary bacteremia is the most common manifestation of invasive pneumococcal disease, and that occurs in around about 70% of cases, and then followed on by pneumonia and meningitis. Whereas adults with invasive pneumococcal disease, most likely it's a pneumonia and with bacteremia. So when we're looking at disease incidence, we are looking at the extremes of the age spectrum. So it's in the very, very young children and in the elderly. Pneumococcal disease has been a notifiable disease in Australia since 2001. So it should be automatically notified by the laboratories that are testing the specimens. The number of notifications fell dramatically after vaccines were introduced for the babies. However, invasive pneumococcal disease rates do remain higher amongst these young children and the older adults. And it's remained consistently higher for Indigenous Australians. So a lot of people do ask, you know, why do we have additional vaccines recommended for Aboriginal and Torres Strait Islander children? And certainly in some states and territories, they have a funded Aboriginal children's pneumococcal program. So it's really important that when you do see your patients, that you are asking the question, do you identify yourself or your child as Aboriginal or Torres Strait Islander? and follow up that question with the reason why you are asking it, so they don't become suspicious that you're asking it for an adverse reason, but just letting them know that if they do identify, then they are eligible for additional vaccines to better protect them from this particular disease. Rates of pneumococcal disease does vary across the country, as you can see, and we've looked at the various age groups that are affected, and this map really just looks at the geographical spread of pneumococcal, invasive pneumococcal cases. So the number of notifications of invasive pneumococcal disease, and this spectrum is, from 2002 through to 2019. And as you can see, it just really doesn't go away. It just sits there and it just bounces around. So how do we get on top of this is going to be an interesting way forward with our new changes to our vaccine program. So if we're looking at non-Indigenous Australians aged 65 and over, if we're looking at the July to September report last year, there were about 264 cases of invasive pneumococcal disease in that particular quarter. And this was a little bit higher compared to that previous quarter, but a little bit lower than if it was a year before. So as you can see, it's just bouncing around. Of those 264 cases, 244 actually had a serotype reported against them, and 64% or 155 of those cases were due to a serotype included in Pneumovax 23. There were 48 deaths in that particular quarter that were directly attributed to IPD, but of course that may well be an underestimate. And 33 of those deaths had a serotype covered by the currently available pneumococcal vaccines. So you can see the different serotypes, and some are not serotyped at all. And there are, in the red bars, cases where they are a serotype that is not in one of our vaccines. So if we are looking at the trends of serotype specific, we can really very, very clearly see that there was a massive impact with the commencement of the 7-valent pneumococcal conjugate vaccine program back in 2005, as well as the 23-valent program for adults onto the NIP. However, we've bounced along quite nicely. We've then had a change over to 13-valent pneumococcal conjugate vaccine for the infants, and our 23-valent has remained on the schedule for our older adults. But you can really see by this particular graph that whilst there has been an impact on those, 7-valent pneumococcal vaccine in the infant program, we're still sort of seeing the 23-valent just still ticking along fairly steadily. So if we're looking at invasive pneumococcal disease by all age groups, you can once again see that there is quite an interesting mix of the different serotypes. So if we're looking at the period of January to September of last year, the number of cases due to the 11 serotypes that are additionally covered in the 23-valent, so in the Pneumovax 23, and also those serotypes that aren't covered by any of the available vaccines, they have steadily just been increasing. So this is surveillance that is very, very important to continue. So following that replacement of the 7-valent with the 13-valent, so with our Prevnar 13 that we have currently got, like we saw, there was that rapid decline, but we're not really seeing that decline continue. It is now just bouncing around. So we need to probably think about what are we doing with pneumococcal vaccines, and a lot of that really is education of patients and making sure that patients are receiving the vaccines that they should be receiving. So who's really at risk and who should be receiving vaccines? It is a very long list of people. It's a very extensive list. And please bear in mind that these are the recommended people. So this does not mean that all of them are funded. So hopefully you have the resources that the Commonwealth have released, which does identify which of these conditions actually are eligible for funded vaccine. Why are people with these conditions recommended to receive pneumococcal vaccine? We'll start looking at those very shortly. But I'll just jump in here and say that the Pneumosmart tool that many of you have used previously to navigate these complex pathways is currently offline because it is being updated as we speak, and hopefully we'll be back online relatively shortly. So let's just tease out a few of those risk conditions. So we know that people with chronic medical conditions such as heart disease and lung disease and diabetes have a greater increased risk of invasive pneumococcal disease in comparison to healthy adults. And certainly multiple risk factors have been observed in individuals over 65 years of age. So the older we get, the more likely that we're going to have a medical condition, and therefore it's going to increase our risk of having pneumococcal disease. And the more medical conditions that you have, the higher the risk, basically. So chronic obstructive pulmonary disease and diabetes definitely shown to be significant predictors of hospitalisation in patients with community-acquired pneumonia, and certainly respiratory and cardiac complications, both of which certainly are associated with increased mortality, is greater in individuals with lung and heart disease than in other individuals as well. So let's just have a look at those conditions and look at the diabetics, for example. So we know that people with diabetes do have an impaired immune response, and it certainly has been suggested that that increased risk of pneumococcal infection in patients with diabetes is resulting from the harmful effects of hyperglycemia on either the immune or pulmonary function, or both. And due to that ongoing subclinical inflammation following the recovery from pneumonia, deterioration of underlying cardiovascular disease has also been associated with an increased risk of mortality within the year following pneumonia in patients with diabetes versus those without diabetes. So as you can see, diabetes is a complication in itself, but diabetes is also usually associated or often associated with cardiovascular and renal disease, which increases the risks. So we certainly encourage providers to follow the guidelines, and of course there's the Immunisation Handbook as well as the Diabetes Management in General Practice guidelines. If we're looking at chronic heart failure in individuals, there was a hospital-based epidemiological study of invasive pneumococcal disease in adults in Belgium, and that particular study did demonstrate a significantly higher case fatality rate during hospitalisation in those with heart failure compared to those without heart failure. And people with chronic heart failure are at risk of a complicated episode of community-acquired pneumonia, and that has increased risk of complications, hospitalisation, and all-cause mortality, but certainly an increased risk of a 30-day mortality. So definitely patients that we need to keep an eye on. Once again, guidelines to follow. We look at the handbook and we also look at the Heart Foundation guidelines. So if we're looking at our chronic obstructive pulmonary disease, so COPD, we do know that because of that ongoing subclinical inflammation that I spoke about earlier, following the recovery of a pneumonia, this definitely has been increases the risk of death in these individuals as well. Certainly, if they have worsening prior cardiovascular disease, that is definitely seen in patients with COPD and has been attributed to long-term mortality following a bout of pneumonia.
Now, Angela, we do have a question from Judy, just regarding patient 40 plus, has had 23. Question is, in 5 years, do they have 13 with a past history of hospital admission for pneumonia?
If it was an invasive pneumococcal pneumonia, that's where the difference you will find will be.
Right.
So had a previous episode of invasive pneumococcal disease, and if that was what that pneumonia was, then they would be looking at having funded vaccine.
Okay, great. Thank you.
Yeah. Okay, so we're up to severe asthma. A lot of people wonder what is severe asthma, and I know that there's been a lot of providers that have just gone, oh yeah, this patient's got asthma, so let's give them pneumococcal vaccine. But realistically, we're talking about severe asthma, and that is really defined as requiring frequent hospital visits or the use of multiple medications. It is not funded under the NIP. The vaccine is not funded under the NIP for people with severe asthma. So, cigarette smoking. I think there has been quite good reason, many good reasons for anybody to give up cigarette smoking if they possibly can, and hopefully you're all encouraging your patients to give up if they are a cigarette smoker, because cigarette smoking is the strongest independent risk factor for invasive pneumococcal disease amongst healthy, non-elderly adults. So that is really quite a horrific statement. And studies of patients in hospital with community-acquired pneumonia, current smokers had a 5-fold increase of 30-day mortality compared to non-smokers or ex-smokers. So just encourage your patients as much as possible not to smoke. So if we have a quick look at the background of pneumococcal vaccines, we've had a bit of a journey, really, starting right back there in 1986. But, you know, the exciting thing about this is that, yes, we've had a change just in 2020, but there will be more to come. Hopefully, we just don't have to keep updating this jolly Pneumosmart tool, because it's quite a significant piece of work. But, you know, we certainly know that there's a 15-valent pneumococcal conjugate vaccine in the pipeline. They are also looking at protein-based serotype independent subunit vaccines. So that could really circumvent the issue of serotype replacement. Or looking at a combined vaccine that includes those pneumococcal proteins as well as the vaccine antigens in addition to that polysaccharide conjugate component. So they're even looking at whole cell pneumococcal vaccines, which are going to broaden the scope of protection. So really interesting work being done in the pneumococcal space. It's a difficult disease. We've got complex vaccine pathways, and it's about really trying to cover as many serotypes as effectively as we possibly can. So watch this space. So Susie, we've got another poll. And in this one, we're looking at the difference between Prevnar 13 and Pneumovax 23.
Okay, and the poll is being launched. Off we go. So the poll is open if you wanted to read through that.
Perfect, thank you. So what is the difference between Prevnar 13 and Pneumovax 23? Is it that Prevnar 13 is a 13-strain polysaccharide vaccine and Pneumovax 23 is a 23-strain conjugate? Is Prevnar 13 a 13-strain conjugate and Pneumovax 23 is a 23-strain polysaccharide? Or they're both conjugates but contain a different number of strains, and they're both polysaccharides but contain a different number of strains?
Great. So we've got about a fairly interesting spread actually across these four answers, Angela. About 50%. So people are just having a bit of a think about it. So we'll give them a few moments if that's
Sure.
okay.
Absolutely.
Okay, so it looks like about 60% have answered. We'll give you a couple more seconds. Pop your answers in. I'll end it in 5 seconds, so get in there. All right, and we're going to end. So I will share the results for this one because I think it's interesting. Can you see this?
Yes, I can. Yes, I can. All right. Okay. So the actual answer is B. Prevnar 13 is a 13-strain conjugate vaccine, and Pneumovax 23 is a 23-strain polysaccharide vaccine. So the difference with those particular vaccines is when I was talking previously around the actual bacteria having a polysaccharide coating, that sugary protein coating, if you like, Pneumovax 23 is made from taking part of that polysaccharide off the bacteria and making the vaccine. What happens with the polysaccharide vaccines is our immune system doesn't really recognise them as a big threat because those sugary polysaccharides are very similar to some of the lining that is around our cells that are in our body already. So our immune system doesn't really know whether it's meant to mount an immune response or not. So we look at the age groups of disease, and we know that our little tiny children are at very high risk of pneumococcal disease. But if we were to give them a polysaccharide vaccine that the immune system doesn't look at as a threat, we're not going to be able to protect those little babies. So with our Prevnar 13, it's a conjugated vaccine, which means that they've taken a piece of that polysaccharide off the bacteria and they've conjugated it or chemically welded it together with another carrier protein. And that carrier protein in Prevnar 13 is a non-toxic diphtheria protein. So when we inject Prevnar 13, our immune system actually responds to the threat of the non-toxic diphtheria protein. And therefore, it calls on our T helper cells to send out a big alert, and our naive B cells can start getting excited and start producing really good antibodies. And along with all of that comes that pneumococcal polysaccharide piece, gets piggybacked along for the ride. So that means that we do get a good antibody response in those little children, which is the age group that we really do need to get this vaccine into. It's also one of the reasons too why we are now giving Prevnar 13 to our older population, which are the other risk group. So there is a difference between the conjugate vaccine and the polysaccharide vaccine. So I hope that I've explained that well for you.
Thanks, Angela. And just a quick clarification for Natalie. Just a couple of slides back. Is the vaccine covered on the NIP for smokers and not asthmatics, just to clarify?
Okay, so smoking is not on the NIP, okay,
Great,
either.
thank you.
All right.
Yep.
It's recommended, but they would have to self-fund it.
Great, thank you for that.
Okay. So if we're looking at our 13-valent pneumococcal conjugate vaccine, we can see here that it is linked to that non-toxic CRM protein, which is a diphtheria protein. It does protect against 13 strains of pneumococcal, because we know that there's over 90 different serotypes of pneumococcus. So Prevnar 13 is to provide protection against 13 of those particular serotypes. And certainly they cause a significant amount of invasive pneumococcal disease in Australia across all age groups. So how does it sit on the program at the moment? Because this is an adult pneumococcal webinar, we'll just let you know here that a single dose of 13-valent or your Prevnar 13 is now listed on the National Immunisation Program. So it's funded for Aboriginal and Torres Strait Islander people greater than or equal to 50 years of age if they have no risk conditions. Non-Aboriginal and Torres Strait Islander people of greater than or equal to 70 years of age with no risk conditions. And all individuals with certain but not all risk conditions. So you do need to look at the tables that are on those Commonwealth resources. Both vaccine manufacturers, so Seqirus for Pneumovax 23 and Pfizer for Prevnar 13, do also have resources that do outline the funding models as well. So just remember, your patients with a hematopoietic stem cell transplant, or HSCT, do require 3 doses, and these are all funded doses, irrespective of what their pneumococcal vaccine history was. So definitely keep that in mind if you've got somebody that has had a HSCT.
Might try and fit in a quick question before this
Sure.
poll goes live. Is a septic arthritis in an 11-year-old an invasive pneumococcal event? Was given Pneumovax 23 as part of treatment. Do they need a follow-up with Prev? From Sarah.
Right. Okay. So if they've had a septic arthritis, do you know, it would have to be if there was an aspirate done?
Yeah, there's no further details from
Yeah.
Sarah, unfortunately.
Okay.
It sounds like it was during an invasive pneumococcal event.
Okay, if it was identified as an invasive pneumococcal event, then yes, they should be followed up, and that's funded vaccine.
Okay, great.
All right.
Thank you.
So the heading in the risk conditions is a fairly broad statement that says previous episode of invasive pneumococcal disease.
Sure. Okay.
So it's whatever of those diseases, as long as it was determined to be invasive pneumococcal disease.
Okay,
Yeah,
what we might do now is go to poll number 3,
sure.
and I shall launch that as we go. There you go, so people can have a read.
Beautiful. So this is the question that comes up probably every single year in regards to giving multiple vaccines on the same day to our older population, particularly with influenza and Zostavax. And now they're going to be receiving a Prevnar 13 as well. So can these vaccines all be given on the same day?
Great. Looks like people are a bit quicker to respond to this
I
one, and
bet
it
they
appears
are.
that the message is getting through, Angela. So we'll just wait a few seconds until we get to at least 70%.
Sure.
Completed the poll. We're very close to there now, and I will share this. Ending in, yep, there we go, and we can share the results.
Ah, look at you. Excellent, excellent. So the answer is D. Prevnar 13 can be given with influenza and Zostavax vaccines. So that is good news. So we try and not inconvenience our patients by asking them to keep coming back for vaccines when they can all safely be given on the same day. Just remember, we just separate our injection sites by that 2.5 centimetres, and we can certainly give all 3 of those vaccines on the same day.
Fantastic. I'm just having a quick check of the questions to see if there's something particular to that. Okay, quick one on the 23 polysaccharide vax. If it doesn't induce much of an immune response, why do we go ahead and use it for Christmas?
Okay, because we need to. Is the bottom line, because it does cover against 23 of those serotypes, and that's really important that we do get some protection against them. You know, quite often we will talk about, you know, 50% of an airbag in a car crash is better than no airbag at all. And it's very much the same as our vaccines. You know, we look at flu vaccine, for example, that, you know, even on a really good year, we might only get around about 65% vaccine effect, you know, efficacy. So they're not perfect vaccines. None of our vaccines, well, very few of our vaccines are, you know, 100% effective in 100% of people that we give them to.
Sure.
But any protection is better than none.
Okay, great. And Chi has asked, do pneumococcal vaccines reduce carriage rates?
Well, interesting, isn't it? Because, you know, we can certainly see the impact that you know, that the introduction of pneumococcal conjugate vaccine into the children certainly made. So we would certainly be acknowledging that it does play a very, very big role in regards to not, you know, giving herd immunity, if you like. But I do understand that you're actually asking, you know, with this particular carriage that we were talking about before, where, you know, sort of 50% of kids carry it, particularly through winter. I would not be able to confidently answer that particular part of that question, but I would love to take that on notice and get back to you.
Great, we'll take a note of that, and if we can put some information on the website on the pneumococcal page with our recording of tonight's event, we will do that indeed.
That would be excellent.
Thank you.
Okay. So with just finishing off with that 13 valent, at the moment for our adults, the need for revaccination is not yet established. So the dose that we're giving them now is the one and only dose that they need at this particular time. Certainly, if we've got individuals that are recommended to receive the 13 valent as well as the doses of Pneumovax 23, it is a good idea, if we possibly can, to give that 13 valent first and then follow that up with the 23 valent. Just really making sure that you observe those minimum intervals. If you are giving 13 valent and this individual has had no 23 valents, then that's great. And you can bring them back. The recommended interval is 12 months to give them dose 1 of the 23 valent. However, a 2-month interval is acceptable. But if you're giving a 13 valent to somebody who has previously received a 23 valent, then you must observe a 12-month minimum interval. So 13 valent is not listed on the PBS. So if an individual does have a medical condition, but it is not a funded medical condition, then they do need to have a prescription and pay full price for the vaccine. So if we move on to our 23 valent vaccine, we do know it covers against those 23 strains, as I was talking before, and you can kind of see here that those, 2007, 2008, there was quite a significant amount of invasive pneumococcal disease that was attributed to those 23 serotypes. So it is important that we still give this vaccine to afford this protection to these individuals. Just bear in mind, remember I was saying that the polysaccharides don't work really that well, particularly in the young children, or especially, should I say, in the young children. So it is a recommendation that they receive their first dose when they are 4 years of age, and then you would follow on with the second dose if that's what's recommended 5 years later. So you've been administering this vaccine for a very long time, can be given subcut or IM, but whenever we've got vaccines that you can give subcut or IM, the IM route is preferred. There seems to be less injection site reactions with IMs rather than with the subcuts. So we do know that with the changes to the schedule now, that where previously we would limit the number of doses of Pneumovax 23 to 3 doses in a lifetime, that is now limited to 2 doses. So if you are seeing an individual who has had 2 doses of Pneumovax 23 already in their lifetime because they have a medical condition, then the recommendation is that they go ahead and receive a 13 valent Prevnar 13, observing that minimum interval of 12 months. And in some people that will be funded, and some people it won't be. But if the person is over 50 and Aboriginal, it's funded. If they are 70 or over and non-Aboriginal, then it's also funded as well.
Now, Angela, we're having a lot of questions about the 65 and 70 age, various questions, different specificities, but a couple of things. Why has it moved is number one. And the other one is, if patients have previously had Pneumovax 23 at 65, no risk conditions, should we still give a 13 at 70? Also for people over 70? If we should they still get a 13 if they haven't had it before, things like that.
Sure. Okay, so let's tackle the 70-year-old. Okay, so if a 70-year-old comes into your practice now, or anybody over 70, so there's no upper age limit, if they are 70 or over and have never had a Prevnar 13, then please give them one, and it is a funded dose.
Great, thank you.
Okay. If, and the same with Aboriginal people, if they have never had a 13 valent Prevnar 13, you would, and they are 50 years or older, then you would give them a dose and it's funded. Now, What was the other part of that question?
Sorry, I did inundate you with questions then.
No,
So the other one was about, I think it was if they'd had 13 by 65,
yes.
when they turn 70, should they have sorry, they've had 23 by the age of 65. Should they have 13 at 70? I think you just answered that.
Yes. So even if they've had 1 dose or 2 doses of 23 valent before the age of 70, they would still be having a Prevnar 13 at 70, just making sure that you've observed that 12-month interval since the last dose of 23 valent.
Yep. And are there overlapping strains between the two?
Yes, there are. Yeah.
Okay.
Yes. So the 23 does contain strains that are in the 13. Okay. There's just 11 more strains that it doesn't, or 10 more strains that it doesn't have in the 13.
Okay, great. Thank you. All right, we'll leave it there for now.
Okay, so if we're looking at 23 valent, how is that now funded on the national program? We know that 2 doses of 23 valent pneumococcal polysaccharide vaccine, which is the PPV, is listed on the NIP for Aboriginal and Torres Strait Islanders 50 years and over, all individuals with certain medical conditions, and children aged 4 years with a condition associated with increased risk of invasive pneumococcal disease. So they would be having that first dose of 23 valent at 4 years of age. Now, just remember that those little children that have got those certain medical conditions as well would be having an additional dose of Prevnar 13 at 6 months of age. So just be aware of which ones are funded and which ones are not funded. Now, previously, 23 valent Pneumovax 23 was on the PBS. It is no longer listed on the PBS. So if you do have somebody with a risk condition that is not a funded risk condition, they do need a prescription and they will be paying full price for this particular vaccine. We've got 4th poll, Susie.
Sorry about the delay there. I'm just doing the chat and the Q&As all simultaneously. I'm multitasking from my safe home in Melbourne. Here we go. It's all launched.
Okay, thank you. So this is your 45-year-old patient. They've just been diagnosed recently with a hematological malignancy. What would be the recommended pneumococcal vaccine schedule for this particular patient? Would you go ahead and give them a Prevnar 13 first and then follow them up with a couple of doses of Pneumovax 23? Or Prevnar first, but then only 1 dose of Pneumovax? Or Pneumovax first, followed by a dose of Prevnar? Or Pneumovax first, followed by 2 doses of Prevnar?
Looks like there's a bit of thought going into this one.
Yes, it's a bit of a tricky question, isn't it?
There's about 50% who have voted. So are you happy to give it a few more seconds for people to consider? Yep. Looks like good answers though. Pretty good result. A few more seconds, 70%, and we'll end the poll in 3. Fantastic. Here are our results.
Oh, well done. Yes.
They're good, aren't they?
They are very good. They are hot on this, I can tell you. So yes, this particular individual would certainly be receiving a Prevnar 13 dose first, and then we would be following them up with 2 doses of Pneumovax 23, and they are funded vaccines for that particular individual with that particular condition.
Great. I'll stop that sharing and let
Thank
you
you.
go.
So it's just really important that we get those minimum intervals right. There's really no such thing as a maximum interval. If somebody doesn't come back in 8 weeks' time or in 12 months' time or something, that's absolutely fine. Wherever a schedule has commenced and we have evidence of it, then we don't restart a schedule. So if they have their Prevnar 13 now and they don't come back for 4 years, then we're just going to be continuing on with this program. We're not going to give them another Prevnar 13 or anything like that. We're just going to start them off with their Pneumovax 23 doses. There's 5 years in between the 2 doses of Pneumovax 23. If they don't come back until 8 years, it doesn't matter. If we've got a documented dose already recorded, then we just are giving them dose 2 Pneumovax 23 today. So we never restart a schedule if there's documented evidence of a schedule already started. So maximum intervals, no such thing really, but those minimum intervals, it's so important that we observe them. Otherwise, it could be viewed as not a valid vaccine. And then we've got a very embarrassing phone call to make to our client to potentially bring them back and maybe revaccinate them. Not only is that horrible for the client, and it's a horrible phone call for you to make, but you know, these are expensive vaccines, whether they're taxpayer funded vaccines or whether the individual is purchasing the vaccines. So we definitely want to avoid that situation wherever we possibly can.
Sorry, Angela, just on that last slide, in that patient, should we aim to give the first dose of 23 at 2 months?
Either is going to be accepted,
right.
whether it's 12 months, whether it's 8 weeks. So that's a clinical decision that, you know, the specialists or the GP may well make on that particular
great.
individual.
Thanks for Arita for that question.
Yeah, thank you very much. That was a good question. So even though this is an adult pneumococcal webinar, it would be remiss of me just not to mention that don't forget that 13-valent is funded as part of the infant program at 2, 4 and 12 months of age. We can give this vaccine from 6 weeks and it can be co-administered with all of those other vaccines that we are giving these little babies. It is a bit of a reactogenic vaccine, and if you've been giving this vaccine, you will note that these little babies cry extra loud when they get their Prevnar 13, so it does sting them. There is an additional dose at 6 months of age that is a funded dose for Indigenous children that are living in Queensland, South Australia, Northern Territory and Western Australia, and children with certain medical conditions once again. So hopefully that's cleared up all of those schedule questions that you've probably had running around in your mind for the last 22 days. If we're looking at vaccine coverage here, nice and quickly, we do know that this vaccine coverage is probably quite suboptimal, to be honest. Different studies have ended up with different results. You know, anything from as low as 36% to as high as 76%, and that would be depending on the general practice that was actually surveyed. It would depend very much on the comorbidities that these individuals have, and certainly how often these individuals actually attend the practice also. So it's very difficult to talk to your patients if they're not coming through the door. Those patients that you do see that they're there on your doorstep every single year for their flu vaccine, definitely they're the ones to keep an eye on, and definitely remind them if they do have a medical condition, remind them about the importance of pneumococcal vaccine and whether it's funded or not funded for them. You know, we are not the bank account manager of our patients. So we cannot say, oh, look, I won't discuss it with them because it's not funded for them and they won't be able to afford it. That is not our decision. Our decision, our duty as a provider is to give all of the recommendations and all of the risks and benefits. And then we let the patient actually decide for themselves to whether or not they will or will not proceed with vaccination. So please talk about recommendations with all of your patients. So in that particular study that was done with patients in those general practices, this particular graph really looks at, you know, those older patients with comorbidities versus the patients that do not have comorbidities. We look at those people that usually do get vaccinated versus, you know, those people that, you know, might have received a vaccine that particular year. So vaccine coverage really for such a serious disease is quite suboptimal. So please talk recommendations to all of your patients. Like I said, the Pneumosmart tool is being updated. It will come back online. So, you know, I don't know when you're going to find time. However, it would be great if you could just, you know, look at 10 or 15 of your patients and run them through the tool and see whether or not they should be getting recalled in for additional pneumococcal vaccines that they're eligible to receive or recommended to receive. And certainly talk to your patients, put those recall reminder systems in place as well. So Pneumosmart tool, for those of you that have never used the tool, it was created back in 2015 once pneumococcal vaccine pathways started to become really, really complex. And the tool has just continued to evolve. It is updated, definitely run through a lot of clinical expertise and experts in the Immunisation Coalition, and I certainly thank them for the efforts that they put into making sure that the tool is an accurate tool for our providers to use. So just remember that if a patient does not have a written record of receiving pneumococcal vaccines, or if they say, oh yes, I have had a pneumonia vaccine, but there is no record of what it was, then we actually do start again, unless you can be an exceptionally good detective and maybe try and backtrack what practice they went to all those years ago, etc. But generally we go on the rule of thumb with the handbook that says if there's no documented evidence of a vaccine, then we start again as though they have not been vaccinated, and the tool will definitely do that for you. The tool will give you that guidance on children less than 5. However, it's not going to work out a catch-up for children under 5 if they've missed any doses. So please use the National Immunisation calculator for that purpose. However, the tool will give you guidance of what they should have received. The tool will also give you hyperlinks to the catch-up tables in the handbook for children less than 5 as well. So you will find the Pneumosmart tool if you just Google or put into your search engine Pneumosmart, it will come up with the tool. There's a couple of ways to get into it, but certainly through the Immunisation Coalition website, you will also find the tool. It does ask you just to accept terms and conditions so you can start proceeding. So just don't forget to tick that little box. So just, we're right on time here. So I'm just going to do this quick wrap up, and then Susie, if there's any more burning questions, we can perhaps get to those. So just remember, this is a really serious disease, and it does cause considerable illness and considerable hospitalisation, disability and death. So we must make sure that those that are most at risk are appropriately vaccinated, and that we certainly use all of the wonderful resources that we have. We've got the ATAGI advice, we've got the handbook, we've got the NCIRS fact sheet, so that's the National Centre for Immunisation Research and Surveillance fact sheets. They've all been updated as well. So remember to have a look at your patients in your practice, and certainly recall them in and definitely talk to them about the pneumococcal recommendations for them. Okay, so
right. Well,
Susie,
do we have some questions for you? Now, I am cognizant of the time, but I'm noticing that most of our attendees, Angela, are so enthralled by what you're saying that they're still online. So if you are happy, if you are happy to take a few questions, we may not get through them all, and I apologise to those we don't, but some of them are a little specific.
Sure.
So let's start with a very quick one about children. Can Prev 13 be given at the same time as flu vax in children?
Yes, it can.
Great.
But please talk to your parents around fever.
Yes.
All right, so flu vaccine in children and Prevnar 13, they're both reactogenic vaccines, and children having flu vaccines can, you know, certainly have high fevers. So definitely talk to parents around looking for a fever, how to take a temperature, how to manage a fever, when to seek medical assistance. They can otherwise be separated by 3 days.
Okay, great. Yep, that works. Now, Liz is asking for your advice on how to explain to patients why the NIP has changed from 65 years to 70. She's saying a lot of asking why that's the case.
Yeah, absolutely. Look, the risk of pneumococcal disease certainly goes up as we age, like I mentioned before. And Prevnar 13 has been shown to be perhaps a little more superior vaccine against community-acquired pneumococcal pneumonia. And that's a really important thing for our older people, because they are at significant risk of community-acquired pneumonias.
Sure.
So aligning it with the 70-year-old Zostavax scheduling point made very good sense.
Okay, good. All right, so if we have a 70-year-old that's having a workup for a lung transplant, they've had Prevnar in about the last 3 years, and they've had Pneumovax this year.
Sure.
Should they have another Prevnar next year, as it'll be, what, about 4 or 5 years? Yeah.
It's just a single dose at this stage.
Okay, all right.
Yeah, no recommendations for another additional dose, but if they've only received the one Pneumovax 23, you would follow them up with a second Pneumovax 23, just making sure that there's a 5-year gap between the two doses.
Okay. Now, Leonie's just asked for possible reactions to 23.
Look, it's reasonably well tolerated. We do see a little bit of redness and swelling around the injection site. There has been reported cases of quite significant localized reactions. However, we would just say it is a localized reaction, and they're better being protected from disease, even if it's going to make their arm sore.
Okay, great. So I'm just trying to filter through these now. Someone with HSCT should have 3 doses of Prevnar 13 was something you might have mentioned.
Yes.
What is the interval? Just the interval for those?
Yeah, the intervals for that. I'll have to be flying off the top of my head here, to be really quite honest. But I think there's one at 6 months, one at 8 months, one at 12 months, and one at 40, no, hang on a minute, one at 6, one at 12, one at 48, or something along that line. No, 6, 8, 12. And then they get a Prevnar, then they get a Pneumovax 23, at 48 months post-transplant.
Yes.
And then another Pneumovax 23 5 years later. Now that's just flying off the top of my head, ladies and gentlemen, so I don't have the table in front of me. Yes, so.
All right, so how are we looking for time? Let's go with, what do you think, one or two more questions?
Sure.
Okay, now just a note for Sonia, check out the chat box for the pricing that you've had a question about. Patricia, if your patients had 2 doses of 23 and they have not been given 5 years apart, should any doses be repeated?
Oh, look, that's a really good question, and it's it would be probably worthwhile, I think, really talking to your state health department in regards to any vaccine that has not observed the minimum interval, to be honest.
Yep.
It may depend on the individual patient's circumstances, and the fact now that they're saying limited to 2 doses in a person's lifetime, yes. I think definitely it'd be worthwhile phoning your local health department to get that advice.
Great. I think, quick one, Gold Card Vets, is the vaccine free for Lorraine?
Oh, that's a very good question, Lorraine.
It's a good question too.
That is a good question, because I am not sure of the answer to that particular question, and I think that would be something that Veteran Affairs would probably be able to maybe answer.
Now, if Lorraine wanted to email the Immunisation Coalition, we could probably chase that up for you down
yes.
the track as well.
Please do. Yes, absolutely. Good. We will definitely do that.
Yep, great. Okay, so I apologise to those who have not been able to have their questions answered tonight, but we will round up and thank Angela so much for once again taking on a huge topic and being really helpful to us all this evening. Thanks, Angela.
Well, that's my pleasure, and we might be able to put all of those questions into a bit of a Q&A and have them up on the website.
I think an FAQ document will be a great idea. So I'll get onto that for our listeners. Now, for those of you who may be listening in a group tonight, just a little note for you that because you won't be logged in as attendees through Zoom, you may need to email the names of your attendees that are on site with you to the Immunisation Coalition, Jane at immunisationcoalition.org.au. Give her the names and then she can process those certificates for you. For the rest of us who have come in through our login and registration, you will receive a certificate automatically, so there's no need to email us to request that. It is mostly done manually at this stage, so please be a little bit patient. They usually come out within the next 2 weeks. So the recording of this webinar will go up on our website by Wednesday next week for your peers and colleagues. You may like to recommend that they hop online, have a listen, and they can actually do those polls through a SurveyMonkey and receive a certificate for the PD as well. Apart from that, thanks again. Stay safe, everyone. Thanks, Angela, for giving us a little bit extra of your time tonight. Well done. And goodbye and good evening to all.
Thank you very much, everybody. Have a safe night. Bye.
All the very best.